So to our final presentation on the series of abdominal imaging, Dr. Zainab will give us a talk about very unlikely things to read in textbooks or articles, which is about omental and mesenteric pathology and the types and the radiological features and differentiations. So,
Good afternoon.
good afternoon.
Okay, first, what's omenta? It's a large double-layered peritoneal sheet that is filled with prominent patches of fat. We have two omentum, lesser and greater. The lesser omentum is attached to the lesser curvature of the stomach here to the liver, and the large omentum attaches the greater curvature of the stomach to the transverse colon. What's the function or contents of the omentum? It has blood vessels, lymph nodes, and nerve.
And fat, of course.
Yeah, of course.
It's basically fat.
Yes, it's made of fat. The greater omentum is the largest peritoneal fold. It consists of a double sheet folded on itself, so it's made up of 4 layers. The anterior 2 layers descend from the greater curvature to the stomach, and the superior part of the duodenum and hangs down and attaches to the transverse colon. As we can see, this is the greater omentum.
It hangs down like that.
Yes. Content of the greater omentum as the lesser omentum: blood supply, blood vessels, lymph nodes, fat, and autonomic nervous systems. Function of the greater omentum. First, protective function. The greater omentum contains numerous macrophages which perform as important protective function. It's a storehouse for fat, so we get energy from it, and migration. When there is inflammation or infection somewhere in the abdomen, the greater omentum travels and wraps itself around this area, so it limits the spread of infection. That's why it's called the policeman of the abdomen. Now we talk about the mesentery. It's also a double layer of peritoneum created by invagination of peritoneum by an organ. It's the continuity of visceral and parietal peritoneum, provides a pathway for neurovascular communication between the organ and the body, and it also has lymph nodes like the omentum. This is the mesentery.
You see, it connects the bowel with the body, so that the bowel stays in its place, doesn't fall.
Types of mesentery, we have 3 types. It's named after the organ that's attached to it: mesentery of the small intestine, transverse mesocolon, and sigmoid mesocolon. This is the mesentery of the small intestine. It's attached to the small intestine.
See, it attaches the small intestine to the posterior abdominal wall.
Function of the mesentery: suspends the small and large intestine from the posterior abdominal wall and holding them in place, and somehow still allows some movement. Also provides a pathway for blood vessels, nerves, and lymphatic vessels. We have many conditions of the mesentery. Most importantly is the acute non-specific mesenteric adenitis. I'll talk about it first. The etiology is unknown, but some say it's maybe associated with bacterial infections like Ischemia infection of the ileum. Others blame an unidentified virus. It's common during childhood and unusual after puberty. The typical history is attacks of central abdominal pain lasting for about 10 to 30 minutes. Also, in some cases, maybe a respiratory infection precedes the abdominal pain. It's self-limiting, no need for medications or treatment, and never fatal, but may be recurrent.
And it's so annoying.
Yes.
Because you always misdiagnose it as appendicitis. So you need to look for the appendix carefully, and you need to look for lymph nodes in the mesentery. If you see the lymph nodes and no appendix, This is mesenteric lymphadenitis, which is, I think, much more common than appendicitis, than real appendicitis. So you always try to, you have two things, appendicitis, which is a surgical, and mesenteric lymphadenitis, which is a non-surgical case. You have to distinguish between the two.
Imaging studies, mostly we use ultrasound as an investigation of choice. CT is usually reserved for older patients if needed at all. Feature on either modality include enlarged lymph nodes, 3 or more tender lymph nodes with a short axis diameter of at least 5 mm clustered in the right iliac fossa, enlarged lymph in lower quadrant, and right lower quadrant. Enlarged lymph nodes are located anterior to the right psoas muscle in the majority of cases, or in the small bowel mesentery. Ear or ileocecal wall thickening may be presented if more than 3 mm.
So
this is all CT.
The thing is, always measure the lymph node in the shortest axis, or shortest diameter, or shortest dimension. Never write a lymph node measuring 3 by 12 millimeter. This is wrong, wrong, wrong. You see the lymph node 4 centimeter in length and 2 millimeter in diameter, you write a lymph node measuring 2 millimeter in shortest dimension. You never measure length. This is completely wrong, confusing, would cause a lot of trouble to the patient, to the surgeon, to the treating physician. Never write long axis of a lymph node. You just write few, for example, axillary lymph nodes measuring 4 or 5 millimeter in shortest dimension, and that's it. Anyway. Let's continue.
This is the ultrasound of abdomen showing large hypoechoic mesenteric lymph nodes in a 6-year-old child with acute mesenteric lymph adenitis.
See, measuring the shortest diameter or dimension.
Yes. Okay. Now another condition, which is tuberculosis of mesenteric lymph nodes, usually caused by tubercle bacilli, history of previous pulmonary TB. Presentation is it could be asymptomatic or with calcified lymph nodes seen on X-ray. The patient may present with pallor, anorexia, and weight loss. Also abdominal pain, abdominal mass due to enlarged lymph nodes in the right iliac fossa, or intestinal obstruction due to the involvement of the ileocecal region of the bowel. This is multiple calcified lymph nodes in the abdomen. Could be accidental finding.
Exactly.
Yeah.
Even in the
It
chest.
looks like the Radiologic calculate.
Even in the chest, we see some calcified lymph nodes every now and then, and they indicate an old TB infection.
Ultrasound may show ascites, peritoneal thickening, and enlarged omental nodes, any signs of infection, the inflammation, multiple enlarged lymph nodes in the abdomen. This is a lymph node. This is free fluid. And
near the gallbladder.
Yes.
And you can see the free fluid also.
Yes.
Here.
This is peritoneal thickening. This is an advanced case
of
TB.
T.
Barium follow-through. When bowel involvement is suspected, the patient presents with subacute obstruction. This is subacute obstruction of the...
So what do we see here? The small bowel looks a little bit dilated, and they are coalesced in the center of the abdomen, clumped together, right?
Yes. Now, mesenteric trauma, penetrating or blunt trauma to the abdomen. The patient will present with shock, abdominal pain, tenderness, and distension. Yeah, signs of trauma. Mesenteric trauma on CT, blood collection in the intermesenteric region with mesenteric fat streakiness.
Streakiness or fat stranding, we call it. You can see this is all contusion. Should be fat. Should be just like that. But since you can see here it's multifocal areas of fat stranding, with history of trauma, of course. And I think there's some gas containing something here, maybe not only on this image, we need more images, but mesenteric injury or omental injury is very likely here.
Now, mesenteric cystis, this is a rare case, a rare condition, can occur anywhere in the mesentery of gastrointestinal tract from duodenum to the rectum. This is a large cyst.
Most of the times we are confused with what? Mesenteric cyst. Hydatid and pseudocyst. Pancreatic pseudocyst or mesenteric cyst, less likely to be hydatid because unlikely to have a hydatid cyst this big without daughter cysts, without other signs of hydatid cyst. Again, this is the
gross
mesenteric cyst.
Now, acute mesenteric ischemia, when there is arterial occlusion or venous occlusion, or we have non-occlusion also, or mixed type. This is a SMA embolus.
This is the SNA, and this is the tunnel defect within the SNA, resulting in this bowel. This is with contrast. You can see the contrast in the aorta, but the bowel is not enhancing, indicating ischemic bowel. It's not getting blood supply.
So when the bowel is ischemic, also the mesentery will. Omental pathologies now. We have omental cysts, also a rare condition. We have true cysts and false cysts. True cysts caused by obstruction of lymphatic channels. They may be unilocular or multilocular and contain serous fluid. Dermoid cysts, they are somehow uncommon and may contain hair, teeth, and sebaceous materials. Now, also false cysts, like pseudocyst of the omentum, result from fat necrosis, trauma, or hematoma, or foreign body. Radiological studies, we have plain X-rays of the abdomen. It may show a soft tissue haziness, presence of bone or teeth in case of dermoid cysts. Barium will follow through. It will demonstrate a displacement of the bowel loops. Ultrasound or CT scan show fluid-filled mass. This is CT.
Showing what?
Dermoids. This is a dermoid cyst.
Describe.
There is a hypodense area.
Okay, there is a lesion seen in the pelvis.
Yes.
Mainly the left adnexial region.
Yes.
It contains wall calcification with mixed contents. You can see some soft tissue density, and this black thing is fat density. And fat containing lesion in the pelvis is dermoid, and maybe dermoid. صح؟
Torsion of the omentum, it's uncommon also, very rare. When the organ twists around its long axis, causing vascular compression. This may vary from mild vascular constriction to complete strangulation leading to gangrene. Radiological features, ultrasound, hypoechoic components, in addition to free fluid in the peritoneal cavity may be detected. CT is the main diagnostic tool and may show fat density lesion in right parumbilical or right lower quadrant, or streaks of whirling sign. This is a whirl sign.
This is the whirl sign, which indicates
malrotation.
الويربول اذا ذاك مال روتيشن واحد ذاك بالارتري هذا بالاومنتم نفسه
caused by malrotation ischemia.